Hey, thanks so much for watching. So this is the Easy EMT program, and we're continuing with a couple of the videos that we're going to be following the curriculum from the Community Health Paramedicine book. It is available from Jones and Bartlett on their website at jblearning.com. It is presented by the American Association of Orthopedic Surgeons, AAOS. So this is based off of their curriculum, which I have a couple of things that I've thrown in there as well. So here we go. We're going to be talking today very specifically about our geriatric population. All right. So our geriatric population in the United States is growing. All right. That's that baby boomer generation that we're starting to see. So when we're thinking about a person who is considered a geriatric person, all right, is any person who is age 65 or above. So that's specifically what we're talking about today is age 65 and above. You're probably going to hear of people of all ages saying they're old, including this guy. I refer to myself as the old guy quite a bit, is because typically I kind of hang out in a younger crowd, and I'm typically the older person, so I kind of consider myself the old guy. But today, the old guy or the old gal is going to be 65 and up. So having a foundational knowledge is going to be really important, which is what we're going to try to do today, is give you kind of a foundation in geriatric medicine, is talking about a broad spectrum of symptoms, all right, that a lot of our geriatric folks are going to complain with. And one of those things is they complain of that generally not feeling well. All right. As a person who works in the medical field, it's one of the things that really always frustrates me a little bit on the inside is when a patient just comes in and goes, "Hey, I don't feel well today." Um, Not feeling well can be anything from a heart attack to having a rash on their backside. It doesn't really give me a lot of things to work off of. What is cool though is it also gives us an opportunity to really dive deep down into what's going on with that person and hopefully be able to discover through a good assessment what's going on with them. These patients will oftentimes have subtle presentations of instability, and we're going to talk about that here a little bit on the musculoskeletal exam, non-specific generalized complaints, which we just did, and a multitude of assessment tools, which we're going to kind of go through a little bit. So our philosophy should be an unbiased approach is when we're communicating with older adults. Number one is we should be very, very respectful. All right. Using terms like honey, sweetie, dear, dude, bro, all of that kind of stuff, not okay. And also be very, very careful about using the person's first name, such as coming in and saying, "Hi, Jill, how are you today?" So let's start off with the very formal Mr., Mrs., Miss, those kind of things. And then ask, once you've introduced yourself very formally, how they would like to be addressed. Some patients will be quite informal and want to be known by their first name, but also understand that we should ask them about their pronouns. Now, some folks maybe get offended when you ask about that, but we never know what their feelings are about LGBTQ and different things. So always ask, all right? Never just assume things. Make sure that we are very professional in our care and conduct, like we should with every patient. But I am always very cognizant of how I act and how I talk when dealing with geriatric patients, because they are from a different generation. And with that, is we want to make sure that we are communicating well with them and being very understanding of the generation that they came from. So one of the things is we want to perform a self-assessment for preconceived attitudes about the elderly. All right. Is we've been around a lot of stereotyping about folks who are those geriatric patients. Number one, you don't, as you get old, you don't suddenly become stupid. All right. That doesn't happen. All right. It doesn't mean that that person is still that person that they were when they were young. All right. My dad is involved in ministry with the elderly, and at the church, and their little moniker that they use is young at heart, which sounds, really, what you would expect from a church group is to have something really cheesy like that, young at heart. But there is something that really kind of stands out to me with that is that they are still very much young. All right. As we shouldn't treat them as something very different. All right. That person who looks like grandma and everything at one time, man, was really really wild back in the day. And so that part of them is still there. All right. It doesn't go away. And so we should see them as a person. All right. And not as some stereotype. All right. Is elderly people can be really, really cool, man. I love doing medicine with our geriatric population, man, as you can learn a lot from them. They're really open to talking with you and sharing, and so see them as a person and not just as that. Well, this is a geriatric patient. So to avoid miscommunication, verbal and nonverbal cues should be caring. Maintain eye contact if it is appropriate, depending on their cultural beliefs. Speak slowly, and there's a reason to speak slowly. All right. It's not to be offensive or anything, but as you get older, your hearing decreases, just part of the aging process. So speaking a little slowly and making sure we articulate each word clearly is going to be able to help them to understand. Avoid using medical jargon, which you should really avoid doing that with most patients. Now, if you're speaking to another medical provider, totally appropriate to do that. But when you're talking to patients, make it really clear for them exactly what's going on in a language that they can understand. Ask patients to explain their discomfort. All right. Don't be one of these providers that goes in and does, on a scale of 0 to 10, what's your pain scale? Yeah, okay, that's going to give us a number that we can use, but ask them to explain it. They're going to tell you, I'm having a little pain on my chest. Give them time to explain it. Don't go in there and give them these really rigid sets of how their pain should feel. Like, is it sharp? Is it burning? Is it stinging? All of those kind of things. No, allow that person to explain to you what is happening. All right. Because when they explain it to you, you're really going to understand better about what's happening with them. And also use the learn mnemonic, which we're going to look at here in a second. And this is a fantastic mnemonic for how we should communicate with any of our patients. So check this out. This is called learn. The first thing is we should listen with sympathy and empathy. All right. Actually listen. When we're listening, we should do active listening. Is when that patient is explaining something, we should respond back appropriately and follow up with what's going on with them. Explain what you are doing. Super, super important. All right. Just don't go in there and start grabbing your diagnostic tools and everything and start doing things. Explain why you're doing it and ask for permission before you do it. Sir, is it okay if I take a blood pressure? They're going to say, yeah. And then ask them which arm that they would like it in. This is really simple. One of the things that I have seen over the years working in EMS specifically is that a lot of patients had no idea why they were being transferred from one hospital to the other. They would go, well, they told me I had to go. Or that they were going because they were having a heart thing. They didn't know what was going on. And I can't tell you how many times I've opened up pictures on my phone to explain to them the procedure that they're having done, or why the doctor wanted them to go for an upgrade in cardiovascular care. It was explaining that to them. And so many times the patients were so grateful that somebody took the time to really explain to them exactly what was going on. So explain procedures, explain the things that you're concerned about, and go through it and do that. So explain what you're doing. So important. Acknowledge the patient's perception of events. All right. It's their illness. It's their emergency. It's them. It's very personal. All right. So we should acknowledge their perception of it. All right. Now, this is really important when it comes down to pain. All right. Is because pain is the personal experience. All right. So a person's pain, a 2 for me could be a 7 to them. And so we have to acknowledge that it's that patient's personal perception of it. We're going to recommend treatment. Now, there are times when we're going to have to do treatment against that patient's will, depending on what their mental status is and that kind of stuff. But we should still recommend treatment. We recommend the treatment that we think is going to be best for that patient. But ultimately, if that patient is alert and oriented times 4, they do have that autonomy to be able to number one, to either accept that treatment, or two, they can also refuse that treatment. It's okay if they refuse treatment. I don't like everything that medical people do to me, and I'm perfectly okay telling them it's not okay as well. And so we should also do that as well. Simple things like they may not want an IV started. That's okay. All right. And we have to number one, recommend that treatment and talk to them. And again, explain why we're doing it, why we think it's a good idea. And at that point, we can negotiate. All right. The patient gets to negotiate, and that's cool as we put that choice and control back into the patient. And when we get that, when we have that choice and control with that patient, they're going to be more involved in their medical care, which is really, from the community paramedic standpoint, is what we want them to do, is because we want patients to be able to self-manage their care. All right. As self-managing their care is medication compliance, getting plenty of exercise, eating right. All of those things are part of that wellness component of them self-managing their care. And that's what we're going to be looking at with our geriatric population. So we need to modify our patient assessment. Older patients, like, they have special challenges. Like, we're going to modify our patient assessment. For example, if we're working with a pediatric population, we need to think about geriatrics is something is just like how children are different. Geriatric patients are different. All right. We don't need to think of them as a typical adult. They are complex. All right. And they have a lot of different complexities within their different health conditions. A lot of them have comorbidities that are associated with whatever their chief complaint is. And we need to look at the patient as a whole and not just that patient's chief complaint. We need to use Occam's razor approach. So Occam's razors, basically the approach that we're looking for, is the simplest explanation is probably the explanation. Evaluate internal and external risk factors. So we're not only just looking at the specific illness, the complaint, but let's take a look at all the other risk factors. So for example, we have a patient who presents to us with chest pain. All right. Let's look at all of the risk factors that are up there. So if they have no risk factors, they just have chest pain, compared to a patient who comes in with chest pain and they have high blood pressure, hyperlipidemia, they also have type 2 diabetes. We know that there are significant risk factors for coronary artery disease. All right. So look at those risk factors when looking at those patients. Investigate any iatrogenic causes of side effects, which is medications, because a lot of our geriatric patients are going to have polypharmacy. Polypharmacy is really dangerous with this population of patients, is because a lot of times they're going to have multiple providers that are taking care of them. For example, let's say the patient we just talked about, they could have their primary care physician, they could have a cardiologist, an endocrinologist, all working and prescribing medications. And some of those medications can interact with each other in a negative way. And so sometimes, guess who is going to figure out these interactions is typically the pharmacist will go, whoa, these don't mix. But we, when we're going out and we're doing our healthcare visits, we should look at all of the medications, make sure we get a good documentation of all the medications and compliance with those medications, and also go back with your notes and everything and go through each one of those medications and see, could they be working against each other or working together to make things worse? So look at all of those medications. Aging is a subtle process, and it's going to happen to all of us. As you can see with the little gray in my beard, it's happening to me as well. And with that process, all right, there are deteriorative changes. And with those changes, some of the things is we can see a reduction in organ function. All right. Your kidneys and your liver don't function as well as they used to. We can see a decrease in the ability to maintain homeostasis, which we're going to talk about in just a little bit, is about changes in the hypothalamus with the elderly, is that it makes it more difficult for these patients to regulate their temperature, either being able to warm up or to cool off. And so they're really susceptible to cold and heat illnesses. All right. We have an increased in disease susceptibility. All right. As we get older, there are things that are going to change in our body. Number one is that our skin gets thinner, so it makes it a whole lot easier for openings to happen in our skin. It allows germs and bacteria to get into our skin. The same thing happens within our respiratory and our GI tract, and allows things to come in a lot easier. But also, we're going to start seeing a lot of disease processes really develop in our geriatric years, is because of all of the bad things that we did in our younger years. All right. If you're young, take care of yourself now. Make sure you eat right, make sure you exercise, do things to reduce stress and everything, is it's going to help you to live longer. Because typically once we get into our geriatric years of life, it's harder to overcome and to treat a lot of these things. You're going to see cognitive changes. Now, cognitive changes are going to happen just part of getting old. Your brain is going to shrink as you get older. All right. So with that happening, your cognitive, those reflexes are going to slow down. All right. You're not as fast as you once were. All right. So your sensitivity, all right, is because of neural changes and the nerves and everything, and your extremities are not going to work as well as they used to and everything. But we can have also gradual cognitive changes that can be associated with disease processes such as Alzheimer's. All right. Now, cognitive changes can either be gradual or rapid. Now, rapid changes in cognitive changes that are rapid and everything, these should definitely be associated with something medically that is going on with that patient. So we should be thinking about disease processes, stroke, patients who are currently having an infection. We're going to talk about some of the different causes of it in a second. But the most common causes of cognitive impairment in older patients is going to include dementia, which dementia is kind of an umbrella term. It's not specifically a disease. Dementia is actually a symptom of disease, depression and delirium. So AEIOU tips. So this is the cause of altered mental status. All right. A is going to be for alcohol and other toxins and drugs. Now, drugs does not just mean, street drugs, the things that we typically think about. Nope. We need to be thinking about drugs that the patient is taking, all that polypharmacy stuff. E is for endocrine or electrolyte imbalances. I for insulin, all right, is because we can see altered mental status due to hypoglycemia. Oxygen and opiates is for O, all right? So we can have a patient who is hypoxic, or they can have inadvertently or intentionally overdosed on opiates. U is for uremia, which includes renal, including hypertension, is because high blood pressure can cause dysfunction in the renal system. T is for trauma, and a number one cause of trauma in the elderly is falls. We're going to talk about that specifically in a second, and temperature issues. I is for infection, and we're talking about infection. One of the big things that causes altered mental status in our geriatric population when it comes to infection is going to be UTIs. P is for psychiatric, and so with a lot of our psych stuff, as we kind of think about, well, they've got altered mental status because they have Alzheimer's, dementia, and everything. We need to find out what their baseline mentation is. And to find the baseline mentation is we're going to talk to the person who is currently their caretaker, whether they're living at home, that could be family, or they have like a health aide that comes around, or if they are in an assisted living facility or a nursing facility, a skilled nursing facility, we need to talk to that staff because they're with them day in and day out, and they are going to know exactly that there has been a change. S is for subarachnoid hemorrhage, space occupying lesion, and seizure. So always interview the patient first. All right, even if we suspect altered mental status or whatever, we should absolutely take the time to talk directly to the patient. Don't talk over them. Start talking to that patient and getting those details that we need, and then ask that caregiver for assistance if we need it. Establish a patient's cognitive baseline during the first patient encounter. So if we're first meeting that patient for the first time, find out and get that mentation from the family and the caregiver. Mental status assessment performed each patient assessment is because we want to get that baseline when we first meet the patient. And then every time after that, as we come back for subsequent visits, as we want to see exactly what the changes are in their mental status. Many older patients have significant cognitive impairment that is undiagnosed. And the only way that we're going to be able to see that and report that back is to get that baseline and seeing if there is any deterioration. Never assume that confusion is normal. Now, can we have confusion that is just part of the aging process? And that is true. All right. I have confusion from time to time, but there is a difference between being confused about a little thing and then having really, truly being confused. All right. Is where it's a cognitive dysfunction. All right. So the baseline GCS that everybody should have, all right, should be 15. That means that they are alert, all right, to person, all right, which means they should know their name, place, the awareness of where they're at, all right, time, as they should know. You don't have to exactly know like the date and time. I couldn't tell you that right now, but they should be able to tell you that it's, sort of around what time of day it is, morning, noon, night, those kind of things. And then E, which is the events, that they're cognizant of what's going on around them. If any of that is altered, then there is something that's going on, and we should not assume that it is normal. So requirement for patient assessment on an older adult does require a greater level of knowledge, and we have to be more comprehensive in our history and physical exam. And so the goal here is to do more, is because we're going to have to dig deeper with our geriatric patients. Is they're going to come out with some really subtle signs and symptoms for us, and they're also can be very vague and what they tell us. And so we're going to have to do more. We're going to have to dig deep to find our answer. The patient assessment proceeds through number one, general information. Now, general information is just where we talk to the patient. How are you doing today? How are you feeling? And just like kind of what I like to call chit chat, patient chit chat. Then we're going to get that chief complaint. Now, remember, the chief complaint is what the patient complains of. All right. So that patient can complain of, I don't feel well today. I just feel terrible. That's their chief complaint. That's it. Now, the next part is the history of the present illness. All right. So they say they don't feel well. Well, we come to find out that when they're not feeling well, that they're having chest pain and they've been short of breath. That's been going on. It's started to increase over the past 2 weeks. That's not the chief complaint. The chief complaint is they don't feel well. So we're going to get into our story. The history of present illness is just that. It's the story that we're getting from that patient, and we're finding out everything that we need to about them. We want to include the past medical history, all right? The family medical history, which is really important, especially when we start seeing disease processes, is finding out if they've got, a little bit of chest discomfort this morning. It's important for us to know, is there a family history of cardiovascular disease, hypertension, hyperlipidemia? All of those different things is because it can begin to paint a picture of what's going on. The patient assessment also includes a social history, and social history is talking about how well the person interacts in their environment. Are they able to do the ADLs, which is the activities of daily living? All right. So are they able to take care of themselves and do the things that they need to do? Do they have help if they need it? All right. What is the condition of their home? All right. Is it well kept? Is it free of hazards? So let's take a look at their medications and allergies. Now, our medications includes not only prescribed medications, but also over-the-counter medication and supplements. And allergies includes allergies to medications, allergies to food, and allergies to things found in the environment. So don't just look at everything, is because it can have a huge impact on what's happening with our patient. Now we're going to do our general assessment, which includes the vital signs and review of systems. All right. So clinical presentation of older patients encompasses a wide range of symptoms. So we should be concerned about any alteration in their mental status. Now, in some patients, their mental status may be less than the GCS of 15 normally. And this can include patients who have Alzheimer's with dementia, and other kinds of different ailments that can happen. And so we want to find out what their baseline mentation is. Let's talk about behavioral changes. All right. And behavioral changes isn't that profound stuff that we see with altered mental status, but behavioral changes, we should also be thinking about depression in our geriatric patient is talking about have they felt more lonely, have they had changes in mood, have they started doing things differently, they made alterations in their life, staying more withdrawn. Those things are important for us to understand. Ask about incontinence. Hate to tell everybody, but as we get older, the muscles in our body don't work the way they need to, which includes the sphincter muscles. And with that is we can have incontinence, and this can be a very normal finding. But we also want to look at incontinence too, is because if you're starting to have increased incontinence, it could let us know that there are different issues that are going on with these patients. Let's talk to our patient about any gait disturbances and talk to them. Are you having any difficulty being able to ambulate, or you're having difficulty walking around your house? Do you have use or the need of mobility equipment such as canes, walkers, wheelchairs? Let's talk about weight loss. All right. In our elderly population, we're going to see weight loss as we get older. And with that, we want to talk about, have they had any recent changes into their weight? And the last thing that we should talk to every patient that is a geriatric patient is about falls. All right. As we get older, again, remember that we're going to lose some of our cognitive abilities are going to change. So we're not as steady on our feet anymore. We start to lose sensation. All right. Our vision isn't as well as it needs to be, and we can have lots of fall risk just associated with getting older. But also, we need to talk about those other fall risks that can be found within the environment of the home, such as loose rugs. All right. The flooring that's not appropriate, stairs, handrails, all of these different things. But also think about outside of the box thing. Does the patient have animals? Well, animals can be a fall risk to the elderly, as if you got somebody who's, a geriatric patient and they're out walking their dog and everything. Dogs are not the smartest things that the good Lord ever put on the planet. And sometimes when you're walking them with the leash, they like to wrap around your legs. And well, that can cause a fall. And so it's talking to these patients about being very cognizant, is because a fall could be very detrimental to these patients. So let's take a look at that general living environment. Is the environment within that patient lives in, does it have good running water, good plumbing, all right, including a working toilet? You'd be surprised how many places don't have that. The other thing is it warm enough? Is it have the ability with good HVAC in order to be able to keep the patient cool enough when they need to be cool and warm enough when they need to be warm? Does it have good ventilation? Do they have an area where they can clean? that's clean, an area in their home that they're able to cook in, and that they have plenty of food and good food, hopefully. So take a look at the overall environment in which the patient lives, but also think about safety. All right. And not just safety with fall risk, but general safety. Is the neighborhood where they live at safe? Our history taking is also going to include the chief complaint. Again, that's what the patient tells us. Then we're going to do our HPI, history of present illness, and our social history, which includes the activities of daily living, which is that basic stuff. Are they able to take care of themselves, to feed themselves, to be able to do some of the basic hygiene they need to. And then we have what's known as IADLs, which is instrumental activities of daily living. And this is complex structure. And so a good example of an IADL would be that the patient can make pancakes, eggs, and bacon in the morning without any assistance would be an IADL. It's a little more complex thing. So we want to review the patient's current medications, and it can be a lot. So we're going to look at prescribed medications as well as over-the-counter medications. A lot of times, patients who are in the geriatric population are going to have a huge amount of over-the-counter medications that they take, which can include things like medication for sinuses. They can be taking NSAIDs for generalized pain. They can be using a cream for arthritic pain, all these different things. But if we don't include that, and when we're looking at the patient's medications, including herbal supplements, a lot of them will take vitamins as well. If we're not taking a look at them as we look at the prescribed medications, we may miss how they interact with each other. So we want to do that as we want to identify adverse reactions. That's the whole thing that we're looking for, is going, all right, is the reason that my patient is feeling this way, is it because of an illness, or is it because they're taking a medication and this is what's going on? And also, one of the things that we need to be thinking about is how the patient is taking medication. My eyes were open recently. I was talking with the nurse practitioner that I worked with, and she was telling me about like when certain medications work the best is when the patient takes them at like certain times. And this came out because of a patient was talking about taking prednisone and was keeping the patient up at night. And she explained to him that if he would dial it back and take it at this time, the last dose, that issue would go away, and it did. And she was also explaining to me the best time to take medications for hyperlipidemia and why they work the best. And so this is really important for us to know when the best time this patient should take those medications, as we should really look at the pharmacology that patient is taking, and understanding that the reason that they may not be able to sleep is because some of their medications, or that things may work better depending on the time that they take it. So we need to really dive in to the medications that our patients are taking, all right, is because it can be part of the problem instead of part of the solution. So our general information, so look around. Is the home clean? All right. Now we have to look, and when I say is the home clean, now my version of clean and somebody else's might differ completely. I have to have everything in a certain spot. My desk here is definitely not clean, but at home, everything goes in a certain place and everything. But to find out what I'm talking about clean is that, that it's safe, that there's not rodents, that there's not bugs and things around there. Is there food in the house? Super, super important. As does the patient have access to groceries? Are there drugs and alcohol? Is it suspected that the patient could be abusing? And then look at the patient's appearance and demeanor. All right. It's just looking at them. Do they look well? All right. Do they look ill? All right. Do they look disheveled? So our history of present illness is going to include OPQRST-ASPN, which includes onset, which is when the time the symptoms began. All right. And then we're also going to Find out if there's any provocation or palpitation. Is there anything that makes it better or worse? The quality. All right. And this is where we get the patient to kind of describe what's happening, the region and where it's happening. And also, does that radiate anywhere, move around? The severity. And then time. This is also the temporal aspects is with time is, all right, was this a sudden onset? Was it gradual? How long has it been going on for? ASPN, which is the associated symptoms. All right. So let's say this patient is having chest discomfort. Associated symptoms could be that the patient is also experiencing shortness of breath and broke out in a sweat. All right. So they're diaphoretic. Pertinent negatives is all the things that it's not. All right. The patient denies nausea, vomiting. And so we can start ruling some of these things out, is putting those negatives that are in there. A complete past medical history should include the patient's history of childhood illness. Very important. We kind of skip out on that sometimes, all right? So if we got a patient who has a rash and everything, it might be important for us to know, did that patient have chicken pox as a child? As it could let us know about shingles and those different things. Let's take a look at the patient's overall medical history, which includes any diseases that they have, surgical history, psychiatric history, and again, that family history. The medications and allergies component. Older population accounts for 30% of all prescriptions written in the United States. Typical older patients takes 4 or 5 prescription drugs and 2 over-the-counter medication. That's a lot of medication. And we want to know what those medications are. Do they have any possible interactions? And also to know if that patient is compliant with those meds. So it is important that we do a medication inventory. So maintaining medication inventory and ensuring compliance are critical to patient care. It is achieved through accurate documentation of the patient's medication. And one of the things is we have to be sensitive is when we're performing a inventory of the patient's medications. All right. It can be looked on as being something offensive is when we're looking at that, as that you're double checking, that you're checking up on them, that you're trying to accuse them of something. Explain to them that it's not that at all. One of the things is we may discover the reason why a patient is not compliant, and we have to be very sensitive to that. All right. Sometimes a patient may not be taking the medication is because of the side effects that it produces. It may be because that medication is too costly and they're trying to stretch it out as long as they can. And so explain to them why you're doing it. Is that you're not trying to catch them in a lie. You're not trying to catch them in trouble and everything. The whole goal here is to help that patient. So evaluate the prescription bottle. So look for the date, all right, and which it was prescribed. Which is going to be important is if we see a bottle that's old and everything and it's got a bunch of pills in it, we know they're probably not compliant with medication. Look at the dose and the quantity prescribed, as we're going to be able to tell if they're taking the medication appropriately. Are they hoarding pills? Are they abusing them? That's the way we're going to know, is having that information on the prescription bottle. One of the other things we need to know for is to look and see if it is that patient's medication. Is it prescribed to them? All right. Old people trade meds. Let's just put that out there. I've witnessed it over the years and everything. It's like the swap meet when they get together with each other at church and stuff. I've seen it at my dad's church. As somebody will have an ailment, I got a headache, and Sister Bertha will pop up and go, "Let me look in my purse. I got a pill for that." And then all of a sudden, we've got a medication that isn't prescribed for that patient and they're starting to use. And so we have to be careful. Substance abuse. We typically think of substance abuse as a younger person's problem. We typically think of substance abuse with somebody who's either a teenager or in their young 20s. It's just kind of how we look at it. But substance abuse can go from any age when there is access to substances. So if we suspect substance abuse, we need to assess the patient's symptoms. All right, is to find out, is there any kind of emergency intervention that we need to do? But we need to also watch for nonverbal cues as we're looking around, all right? A lot of times, depression and substance abuse in our geriatric population go hand in hand. So we're going to obtain a medication inventory. And again, we're not accusing these patients. You know, we're not the police. All right. What we are trying to do is to help them, is because we know that substance abuse is going to cause deterioration in that patient and could possibly cause death. And we want to prevent that. So with our physical exam, we're going to use our 4 major techniques, which is inspections, where we look over things. All right. As one of the big things is looking at the patient's skin. Palpation is where, yep, you got to touch them. You got to touch a patient. So we're going to palpate. Percussion, which is tapping, and we're going to do that on several of our exams. And auscultation is where we're going to be listening. 4 clues to the patient condition and underlying disorders. We will want to observe the patient's behavior. And that's that general behavior. We're not talking about behavior when we're thinking about psychiatry. This is just a general how they are. All right. As we're looking how alert they are, their alertness, all right, how well with it, what their grooming is like, their personal hygiene, and also their facial expressions and demeanor. All right. It can tell us a lot about what's going on. All right. So we may consider using the 5 eyes of geriatrics. All right, so here we go. So here's the 5 eyes of geriatrics. The first eye is called intellectual impairment. All right, are we witnessing and seeing any difficulty in an intellectual impairment? All right, are we seeing signs of altered mental status? All right, are we starting to see the deterioration of that patient is where they're not as with it? Immobility. All right. So we need to do that get up and go test and see if that patient, how well they're able to move about their environment. All right. And if they are immobile, all right, they're not as able to get around, or they're bedbound and everything. We know that if we have immobility issues, that we're probably going to have skin issues as well. Think about instability. What kind of goes along with the immobility is, do they have anything that would make them unstable? All right. For example, if you have a patient who has recently had a stroke and they have hemiparesis on one side, and that patient is going to have some instability, and that puts that patient at risk for a fall. I is for incontinence. All right. This should be part of our normal assessment with our geriatric population, is seeing, has there been any changes in their bowel? And the last thing, as iatrogenic disorders, are they having any medication interactions? So let's take a look at our skin assessment. Now, our skin assessment is very important in the geriatric population, as it can help us to determine underlying disease processes. All right. For example, if we start to see jaundice, we know that there's some type of hepatic problem that's going on just by looking at their skin. But one of the things that we should look for is skin turgor, which is any elasticity. All right. Are we seeing the thinning of the skin? Are we seeing bruises? And bruises can also let us know that there is potential for abuse, but we can have bruising that's could be from falls, but bruising that could be if the patient is taking medications, like blood thinners, for example, can cause bruising. So let's look at the color of their skin. Let's also look for open wounds, if there are any. And if we do have open wounds, we should note them and continue to look and see if they're healing appropriately. So let's take a look at our head and neck assessment. So look for signs of head or face injury. A lot of our geriatric population are not going to tell you about falls. All right. You're going to find bruises, skin tears, and different things that will show you trauma. And then that's how you're going to discover about falls. The reason that these patients are not very forthcoming about coming to a provider and going, okay, well, I've been falling at home, is because they don't want to lose their independence, is because that's a huge thing. They don't want to lose that. And so don't come down on these patients and go, you didn't tell me about that. Well, I'm a very independent person. I don't want to lose that when I get older, so I can definitely understand that. And so have some sympathy. So look for those signs of head or face injury. And so falls can be super, super very detrimental to that patient's health, especially if they strike their head, as it can lead to traumatic brain injury. If there is a head injury, look for altered mental status during your neurologic assessment and use caution when palpating the neck and back. All right. Is even just the slightest fall is where they drop down and have a ground level fall could result in fracture to the neck and spine. Cardiorespiratory assessment. So a lot of our patients that are above age 65 are at risk for developing cardiovascular disease. And we tend to start seeing like young cardiovascular disease in the 40s, but later on in the 60s, we can see things like myocardial infarction that comes up. We can also see other vascular disorders in the heart. We can also see arrhythmias that develop later on in life, especially AFib, which becomes very common in age 65 and above, which puts them at risk for stroke. So, and they're going to have maybe some circulatory dysfunction as well. So as we're looking at the circulatory function, we want to listen to heart sounds. We know that S1 and S2 are the normal heart sounds that we should listen to, which is a lub-dub sound. S3, if we do have S3, it can be indicative of congestive heart failure if we hear S3. Also look at the heart rate and the blood pressure. So make sure that when we're taking the blood pressure that the patient is calm. We give them about 5 minutes before we start taking the blood pressure. We also want to make sure that they're seated if possible or laying down. All right. That their legs are not crossed, their arms aren't crossed, those different things. So also we need to look at circulation abnormalities such as resistant hypertension. But also with circulation abnormalities is we need to look at the patient's extremities to see if there's any swelling, those kind of things. So our airway function, aging, there are some aging related changes. One of the big things is as we get older, the amount of capacity that we have in our lungs is going to be decreased. And with that, just normally, it makes it harder for a person an elderly person to be able to breathe. And so that's why they get winded, okay, easily. And this can just be normal. And this is what happens. Not only that, but we have rigidity that happens in the chest wall. And so we need to do a good assessment of the respiratory system. Now, when we're auscultating for lung sounds, we need to start at the bases. Instead of looking at the top, we're going to start at the bottom, at the bases. And when that patient takes a breath, we may hear some crackles that happens initially. Wait a second. Listen again. A lot of times those crackles will move away. And that can be a completely benign finding in that. When we're listening, we can have something that's called egophony. All right. Egophony is an increase in resonance of voice sounds during auscultation. And when we have this lets us know that lung fibrosis is present. So what we're going to do is have the patient say the letter E when we're listening. So when they say E, what we'll hear if we have this with egophony is that it'll sound like A. So the patient will say E and it'll sound like A in their lungs. One of the other things that we can have is called bronchophony. And bronchophony, normally when the patient says 99, the sound of the patient's voice becomes less distinct as auscultation moves away. With the presence of pneumonia, however, which within bronchophony, the patient's voice remains loud throughout. If we have pneumonia, we'll be able to hear it loud throughout. Normally, it should be diminished with the patient's voice. And this is part of our physical examination when taking a look at the respiratory system. Our neurologic assessment. When we're performing our neurologic assessment, observe that patient within their environment. All right. Determine the patient's orientation again to person, place, time in the event. That's at alert and oriented times 4. The normal GCS should be a GCS of 15. If that patient is impaired, we need to determine if that impairment is either chronic, which is something that's been going on for a while, or is it acute? Things that are acute, when we have that sudden neurologic dysfunction, that needs to put us on high alert for stroke. So our neurologic assessment should also include a psychiatric assessment as well. In older adults, depression coincides with physical disorders, disturbances, or loss. So with a lot of our older patients, what we're seeing is that um, our patients, there's a lot of loss. You're going to get to an age is that one day you're going to start making a lot more friends than you are. When you're younger, you make more friends and you lose them. As you get older, you start losing a lot more friends. And it can be very depressing. One of the other things is there can be that loss of independence. They can have more illnesses and stuff. And so depression can go, a lot of our geriatric patients are depressed. So we need to use the geriatric depression scale to assess the risk. And so here is the geriatric depression scale. You can find this all over the internet and everything. And it has 15 questions. So a score of less than 10 is an indicator of depression. So one of the things I'll do is I'll put a link to this video of the geriatric depression scale for you guys to look at. So dementia is a slow process of decline cognitive functioning. It must be cognizant of contributing causes that produce dementia-like symptoms. And dementia is, again, that's an umbrella term. Now, here are the top causes of dementia. Now, Alzheimer's causes 50 to 75% of all cases of dementia. Vascular issues, 20 to 30%. Lewy body, 10 to 25, and frontoperioral is 10 to 15% as the causes of dementia. So we just talked a little bit about dementia. Now, dementia is more a gradual onset. Delirium is a rapid onset and it is brief in duration. Delirium is reversible. The incidence of delirium increases with age. Signs of delirium involve cognitive impairment, confused, agitated, rambling, those kind of things. It can have intrinsic and extrinsic factors that may contribute. All right. Delirium can be a true medical emergency, and those patients need to be taken care of as quickly and safely as possible. All right. So with our geriatric population, we're also going to have changes in the way we do an abdominal assessment. Is we need to understand that with our geriatric patients is that organs may not be in the same location as in a younger patient. And so they may not be where that we would normally find them. So it can be a normal finding with those patients. So when we are looking at patients and doing a good abdominal assessment is older patients can have a blunted immune response. All right. So these patients who are having difficulty with their abdomen and everything, as their bodies are not going to have that normal immune response they may not see. So we may not have those typical symptoms of pain or tenderness that we're going to find on physical findings associated with abdominal complaints. And those complaints can be quite vague. All right. As one of the things is these patients may not have that normal inflammatory response that we see with younger patients. So doing a musculoskeletal assessment, the normal pathophysiological changes are going to be a little bit different. All right. So we want to make sure that we are evaluating the patient's range of motion. by doing a good range of motion exam is doing the active range of motion and the passive range of motion. One of the things, a tool that I highly recommend all community paramedics having, is because we're going to be seeing these same patients again, and we want to see if we are seeing deterioration or improvement, is to use a gonometer, is to be able to use it and to be able to see exactly what that patient's range of motion is to have an objective assessment and an objective tool to be able to see if we're having going in the right direction or not. Our geriatric patients can have reduced movement, is just part of getting old. They can have those very vague complaints and signs of pain and stiffness and weakness. A lot of those patients can have difficulties with arthritis, and some patients may have kyphosis. So be familiar with typical deformities of the fingers that can indicate things such as osteoporosis, osteoarthritis. And look at the rule of symmetry, all right, is to look, instead of just looking at one side, is to look at both. Symmetric findings are more likely to be normal versus asymmetrical. So trauma in older adults, again, the number one cause of death with traumatic injuries in older adults is going to be falls. So consider the possibility of injury, even if we have like a motor vehicle accident, for example, is the mechanism of injury is going to be increased. All right. A light strike to the chest in an older adult could cause significant injuries, such as fractures to the chest, injury to the lungs and to the heart, that we would not see in younger patients. All right. So we want to definitely look at and understand that there can be more serious injuries than what we're just seeing based off of the mechanism of injury. These patients are going to have increased risk of falls, is because their vision is not as well. The sensory is not as good as it needs to be, and so there's increased risk of falls. And this can also have iatrogenic causes, which can be medication side effects. A lot of medications that our geriatric patients take could make them dizzy, drowsy, can have them where they're impaired. All right. The leading cause of death in the United States for people over 65 years of age and older is falls. So if a question of injury, inspect the patient's physical appearance and assess for abnormality. So with falls, all right, if that patient is living alone, it could be that that patient has laid there for quite a while. And because they've laid there, they can develop other associated issues that are secondary to that fall. Right, the fall, we may actually have the injury itself. Maybe they have an injury to their hip, but we can also see if they've been laying there for a while. We can have abscesses from skin breakdown where they've been laying there for a while. They can become septic because they've been laying there and develop infection from incontinence and different things that we can see. But depending on how long that patient was laying there, these patients can also develop rhabdo. So ask lots and lots of questions. Don't just assume when you walk in the door. Better to doubt the patient's story and discover medical problems than to miss a potential life threat. So ask lots and lots of questions. Dig down deeper until you find the truth. We should be aware of types of abuse. Now, we typically think of abuse as just that physical abuse, the bruising and different things, but there's different types. There's physical abuse, which is that, the marks and things that we see. Sexual abuse, neglect. All right, we see this a lot in our elderly population, is neglect, especially when patient is dependent on a caregiver. Exploitation, which goes hand in hand with emotional or financial abuse, and abandonment. All of these things, please make sure that you check within your specific protocol for the state in which you're practicing. It is typically required for you to report abuse or suspected abuse and to know who to report that to. Physical signs of abuse can include slap marks, unexplained burn marks, and unusual bruising. But ask about unusual bruising. This could be a normal finding for patients who are on medications such as blood thinners, or their skin is thinning, or it could be bruising that could be from falls. All right. So be very, very on the, I guess, to be, man, just let your, that alert come on in your head and be, thinking about bruising around the breast or genitals to put you on high alert for abuse. So here are some of the common complaints of geriatric patients. All right. Shortness of breath, abdominal pain, dizziness and vertigo, fever, generalized pain, nausea, vomiting, and diarrhea. This is typical for any of those. But think about shortness of breath, abdominal pain, could be life-threatening complaints. All right, could be signs of something cardiovascular going on. All right, dizziness and vertigo could be a sign and symptom for things such as a stroke or other neurologic dysfunction. Fever. All right, the elderly is anything that's 2 points greater than what their baseline temperature is they can normally have a temperature that's around 99 normally, 99 to 100 normally. If it's 2 points above, it's considered something that is urgent and needs to be taken care of, because it could indicate severe infection, including sepsis. Generalized pain can be an indication of traumatic injury. Nausea, vomiting, and diarrhea could have a myriad of different causes, not just on the GI side. All right. Nausea and vomiting, for example, could also be associated with stroke and also be associated with cardiovascular disorders. So just because it's a common medical complaint, dig deeper, is because it can be very vague and lead to bigger problems with our geriatric population. So all in all, guys, what we're looking at is doing better when it comes down to geriatric care, is seeing them as a different population with different needs, different disorders, and how those patients present with those disorders. So it's important for us when it comes down to geriatrics is to dig deeper, do better, do a good assessment, and you'll start finding things and hopefully being able to help those patients to live a longer and healthier life. So thanks so much for watching.